Welcome, everybody. Thank you so much. Welcome to Cervicogenic Involvement in Mild Traumatic Brain Injury. So my name is Dr. Chris Slininger. I'm a craniocervical specialist and the owner of Cerebral Chiropractic Center here in St. Petersburg. I'm really excited about today because we're going to be diving into a topic pretty deep in a way that I have not personally seen presented. This is something that I've been working on for about 12 years. And so I really want to open this up as a time to first explore the concepts, and then we're going to end with some Q&A. So we're planning a 2-hour presentation. I could talk for a lot longer, but I'm not going to. We're going to take a pause at about an hour so we could use the restroom, get some coffee if you want some, and then just enjoy that. So thank you all so much for your time. First and foremost, I really, really appreciate it. More than you know. I don't feel like it always needs to be a large group. It needs to be a caring group that you start with. And so this is an introduction of some concepts that's designed to work in collaboration with already existing mild traumatic brain injury interventions and even true traumatic brain injury interventions for personal injury, for your common head injuries, sports injuries, military mTBIs, and blast injuries. There's components to all of those that we will be covering today. So a little bit about what we'll cover. Actually, before I dive into that, I do want to introduce Synapse Continuing Education for a second. So Cerebral Chiropractic Center is the clinic we work out of. It's the stationary clinic that we actually provide the care. Synapse Continuing Education is designed to be a cross-professional, collaborative platform to educate between fields. So often when we get into continuing education, it's very common that people in one profession will train the people within their own profession. It's very siloed. And so Synapse is supposed to take the walls out between the professions so that when one profession has some information that would benefit others, then they can share it, and that cross-professional collaboration elevates all providers together. So even if you don't provide the care, you have the knowledge and understanding of what another field would see and understand, which makes us all better providers. So Synapse is not just a platform for one person or one profession. It is truly a place of collaboration, and we will be doing live and online training, and this will continue to expand into topics that are either very challenging or even very controversial by bringing in people who can kind of shake up the status quo a little bit. So we're going to have fun with it, but it is designed to be in-depth and innovative. So we love that you're a part of this today. What we're going to be covering today, hopefully you can everybody read this fine? Okay. So we're going to be reviewing craniocervical anatomy, right? Today, although mTBI is a very large topic, Jerry, don't even worry about that one. Something's off with that. These two work really well. So we're going to be reviewing craniocervical anatomy. This topic is very specific about craniocervical involvement in mTBI. We're going to try to limit our conversation, even though we could go really wide and really far with it. We'll talk about some craniocervical biomechanics, just some basics in that. We can go a lot deeper, but I think it would take up too much time today for the important things we're going to be covering. Craniocervical hydrodynamics, including cerebral blood flow patterns and cerebrospinal fluid hydrodynamics. This is going to be really key. Again, we're gonna skim the surface, but kind of expand the topic a little broader than it's typically discussed when we're talking about brain injuries. A lot of times we limit that conversation to what's in the cranium, and we're going to go a little beyond the cranium today. Traumatic structural effects of an mTBI to both the brain and the craniocervical junction, pathophysiological effects of an mTBI, that we're going to dive really deep into. We're going to talk about how common mTBI symptoms are related to these pathophysiological effects, and then describe the differences between head impact mTBIs and blast injury mTBIs, including the differences in the pathophysiological cascades. Now, they're two common words, but I've never heard it described that way. A lot of times we say what symptoms are related to mTBI, and we're going to take a different perspective at that topic and say, well, clearly there's symptoms that are related to mild traumatic brain injury, but why are they there? And we're going to see if we can trace it to some very concrete roots. And that way we're looking at it as a cascade, just like a waterfall would cascade downward. Whatever's upstream causes the downstream effect. And so if we can get all the way upstream to where some of these things are originating or potentially originating, that's actually when we can start to see how to turn off the cascade. Some of them are more concrete than others, just to be clear. Now we're going to be talking about effectiveness of common mTBI prevention tools a little bit. Very, very brief on that one. And we're going to be describing some imaging types for mTBI and what they say. Today we're going to only introduce some new ones that would be beneficial instead of scour all of the available imaging. This is an area that has definitely made leaps and strides in the last few years, where we understand how to look at the brain, evaluate the brain, and test the brain in ways that are giving us very concrete data. And we're able to do those tests both before and after treatment. So we're seeing the effectiveness of the treatment on the brain's health, function, and activity. Then we're going to be talking about rationale and effectiveness of craniocervical interventions on brain function, brain chemistry, neurodegeneration, and common symptoms. And then lastly, we'll talk about the rationale and effectiveness of various early, late, and end stage interventions. It's a lot. It's a lot. But again, I want to make sure we have a big top-down view of this idea. Okay. I had a patient who was a farmer once. This guy was funny. He always came in, he cracked jokes, and once in a while he'd have like farmer wisdom. And one day he came in and he goes, "Hey doc, do you know what the difference between knowledge and wisdom is?" I said, "Well, I know the difference, but I want to hear what you have to say." He goes, "Well, doc, knowledge is knowing a tomato is a fruit, and wisdom is knowing not to put a tomato in a fruit salad." And I was like, dang it, that's the best description I've heard of the difference between the two. And it has stuck with me all these years. And I share that story so many times because I remember that day when he said that. I walked out into the hall of the clinic I was in, and the first thought I had is knowledge is knowing a pharmaceutical changes the way the body works. Wisdom is knowing it's a toxin to the body. It was the first thought in my head. And I was like, we have got to have wisdom again when we approach these topics. We have to think with a clear mind. And I love the farmer simple concepts. It's powerful. In fact, it was a couple years later, I was remembering that story. I was like, what other kind of farmer wisdom can I find? Right. And this is so relevant to what we're talking about today because I went online and I think it was just browsing. I must have been on social media and I saw this little clip and it said like 30 nuggets of farmer wisdom. And I was like, all right, I'm going to click that thing. So I click it and I start reading and I'm like, I'm laughing out loud alone because of how simple these statements were and how profound they were. And there was one in particular that I remember so clearly. I mean, I stopped in my track and this is the whole phrase. It said, "A bee is faster than a John Deere tractor." That's it. And I'm like, oh my gosh, that is the difference between a scientist and a farmer. See, scientists will go, what's the bee's like maximum velocity and the trajectory and the ability to turn really fast? And what's the horsepower of the tractor? And a farmer's like, none of that matters if you don't know the bee's faster, right? You get out of the tractor and you run and you take cover. You don't want to get stung by bees. And what sticks out to me about that is sometimes we can get so buried in the details of the science and we almost lose sight of the plain as day statements that sum things up. And so the way I look at mild traumatic brain injury and what led me to a lot of the questions that I asked to get to where I'm at, it was this idea that it should just make plain sense. Like we should be able to propose a theory that everybody could just go, yeah, that makes perfect sense. And then the science side of it is the ability to get detailed and test to see if that common sense observation holds true. So I always like to approach it that way, and we're going to do that a little bit today. We are going to dive really deep, but don't lose sight of this broader wisdom. Can we simplify it? And so in the scientific process, obviously we make observations, we ask questions, right? And we propose hypotheses. And that's exactly what happened with me. You know, I was introduced to mild traumatic brain injury when I was in athletic training school. And the number one thing that was hammered in is that it's primarily a brain injury. And what else are you going to do with that? It makes sense. It's called a mild traumatic brain injury. You get hit in the head. And so the assumption is that. And by no means am I saying it's not a brain injury, but it was that it is an injury to the brain specifically, end of story. And I went with it. And as I continued through athletic training, I was like, I think there's some things that aren't being resolved here because we're approaching it as only a brain injury. And then when they're cleared and everything is good, they still have these persistent symptoms. And that's where this whole questioning process came up. And a lot of it has to do with this idea of a first premise, right? If I if I assume MJ hates me, I'm going to talk to her and behave a certain way with the assumption that she hates me. I don't think she hates me. Pretty sure she doesn't hate me. But if I thought that based on my first premise, my first assumption, my actions, thoughts, behaviors, and interpretations will be skewed based on the first premise. That's this idea. And so in the mTBI world, I looked at this when I said we have a strong first premise that the mTBI is primarily a brain injury, but I had questions. And so these are the big ones. I want you to kind of get in my head so you can understand why I'm even going down this road. Number one, do the forces of mild traumatic brain injury have the capacity to affect structures other than the brain? That was the first question. Are those structures related to brain function? Right? If you got a head injury and it could break a finger, is the finger related to the brain? No, it's not going to really affect brain function, but there's some closer structures that might. Would a disruption of these additional vulnerable areas account for some of the symptoms related to mild traumatic brain injury? If so, which ones and why? Right? And then could they be the root cause of some of the symptoms that we see? That was the series of questions. So this is the hypothesis that was proposed. There might be something outside the brain that's getting affected. Let's find out. So I'm not going to repeat this. We have the recording of the presentation where I went into a lot of depth, but the background in athletic training basically started this whole cascade of thought where I started to see that the cranial nerves being tested field side were coming from the brainstem, but we were assuming it's a cortex injury, and yet the brainstem was showing the dysfunction. Right? Brainstem sits in the lower part of the brain, goes through the foramen magnum, and some of the lower portions of the brainstem can go as low as C2, especially the trigeminal nucleus. Here's a good illustration of where it actually sits. Okay? So when I was in the military, I got introduced to this idea that the brain hits the inside of the skull. I want to clarify something from the last presentation because there were some people that that had some questions about this. What I had talked about how when this concept that the brain smacks the inside of the skull, this is one of the more original concepts that it's very hard to actually do in a truly hydrodynamic environment. That you would have to have aerodynamics to be able to get the brain to speed up fast enough to smack. It does not mean that there can't be increased pressure at the point where the brain does approximate the skull, which can spread apart the nerves. It can cause shearing effects. You can also have axonal shearing when you have rotational injuries like uppercuts, fast rotational hits, things like that. So there are absolutely forces at work that can cause direct brain injury. It's provable, it's observable, and it does need to be directly intervened. For the sake of today's conversation, if we could, can we take all those direct brain injuries and put them aside, knowing that they are real and they are there? What I want to do is expand the scope of what we're looking at to an area that gets talked about less and may account for some of the symptoms that we see commonly in both very mild, like low impact, mild traumatic brain injuries, even all the way up to full blown, very intense blast injuries. Okay. So we're going to skip hydrodynamics because I covered this last time, but these are some of the most common symptoms that we see in mild traumatic brain injury. And even though there's widespread incidence, I truly believe this statement is true that post-concussive syndrome, the syndrome itself, these symptoms that are really common, is poorly understood. So headaches, sleep disorders, visual disturbances, ringing in the ears, memory difficulty makes a little bit more sense. Cognitive issues does make a little more sense. Some of the motor disorders, we're going to explore some of the mood changes, and speech difficulty is very interesting. Now, this one does make sense if you have direct damage to some of the speech centers, but there's other things that can contribute to the ability to properly speak. So that's what I'm talking about. All right, we're going to skip the models, right? There's current models, there's impact model, there's brain sloshing model, there's axonal shearing models, there is some other ones. We are going to introduce a different concept. So again, for the sake of this conversation, we are talking about mild traumatic brain injury, not traumatic brain injury. And this isn't textbook, this is Dr. Chris's definition here. Mild means I can't see damage to the brain. Right? Traumatic brain injury is there's the damage. Okay, I can see it. It's observable. So this is the one where we go, well, where's the symptom coming from? I can't see the damage. That's what I'm talking about today. All right, I'm going to skip through this really quick. Give me 1 second. We're going to pick up at first premise, okay? Okay. If the mild traumatic brain injury is a brain injury, just like if MJ hates me, I'm going to make assumptions about what she means by what she says, right? It leads us to think certain ways. We will naturally, if we assume that the brain is the primary thing being injured, we will evaluate the brain, and typically only the brain, to see where the brain injury is. It would naturally confine our observing area to the cortex. If I don't find any findings, which again, we're talking about mild traumatic brain injury, I don't see anything, and I'm just seeing symptoms coming from a known head impact, the common trend, not you guys, the common trend is that we would manage symptoms. It's a symptom model. And so a lot of current policies, and my biggest critique is going to be the Department of Defense's concussion management protocols, the current ones that are published, are still focused on this, that we don't see the damage, so we watch and wait, and we provide pharmaceutical help to manage symptoms, maybe do a little physical therapy, but that is the typical published protocol. They are moving outside that box. I see the changes, but when you look at the publication, that's the standard of care right now. And so the lack of functional results through symptom management only reinforces that the brain does not heal. I have had veteran after veteran after veteran, specifically the veterans come back from the VA, you know one in particular, who have literally looked them square in the eye and say, the brain doesn't heal, you need to learn to live with it. Hard, even after being challenged with science, with the current studies that are showing it actually does heal. Absolute refusal, you need to accept this, get on with it, you have to learn to live with this dysfunction. And the frustration level of these veterans is insane, okay? The personal injury world is moving forward, I believe. I think they're advancing faster. But again, sometimes in the personal injury world, as opposed to the military, personal injury can be steered by who pays and what they pay for. And so even if something proves to be true, if it's not compensated, a lot of times businesses will default to the therapy that is safe financially, not safe for the patient necessarily. It's a tough reality. It's a tough reality. So here's my challenge, right? When I observe this mild traumatic brain injury landscape, let's call it just a broad landscape of intervention, we often say there was a head injury or a blast injury and it causes these symptoms, and we know about them. They're documented, they're well researched. Common ones like PTSD, craniocervical syndrome, operator syndrome in the military, mental health issues, and suicide tendencies can be very common if left untreated for long enough, or if the injury was severe enough. or repeated head injuries. We know these symptoms exist. I think the better question is, how did they get that far down that road? What's driving it? And do we just suppress it? Do we try to just shut down the PTSD itself? Or if there's a logical reason why they have PTSD or craniosacral syndrome or operator syndrome or any mental health issues or decline, like what would drive that? Okay, I love this example. It's the check engine light in the car, right? I haven't told you this one yet, but if you are driving down the road and your car is like not starting very well, it's clunking around, making weird sounds, electricity's going in and out, and the check engine light's on, you go to a mechanic. Imagine a mechanic's like, hey, just come back in 3 hours, we'll check it out, let you know what's going on. So you leave for 3 hours, you come back. He goes, okay, car's good to go. That'll be $300. Go, well, what did you do? Well, I put tape over the check engine light. You'll be fine. Right? You'd be absolutely outraged at the mechanic. But the funny thing is, if your body is throwing off all these warning lights, hey, I have this symptom over here. I've got headaches. I'm not thinking very clearly. I'm not sleeping at night. Like something is not right. These are the indicators of a problem. If you are given a therapy or a drug that masks the symptom without popping the hood and figuring out what's driving that symptom, it's the same as a mechanic putting tape over the check engine light. And yet we thank the doctor and we're outraged at the mechanic. And our body's quite a bit more valuable than the car we're driving. It's a weird mentality that we've accepted as normal in this industry at large. And when I see things like that DoD concussion management protocol, which is literally saying manage the symptoms with pharmaceuticals, all I see is a giant check engine light with tape over it. That's not helping these people. So we got to stop that. All right. Basically, if somebody ends up with symptoms, right, they end up with a health declining so much that they're becoming symptomatic. This would be the symptom threshold. If they're down here, a lot of times we're giving them drugs that are just lowering the threshold so they don't feel the problem without their health actually increasing again. So just imagine that if perfect health is on the top and death is on the bottom, you want to be driving the function of the body up, not the symptom threshold of the body down. One will hide it, one will heal them. I have too many animations. I'm sorry. All right. So this is where that series of questions stepped in. I said, maybe the problem isn't that we just have the wrong therapy to deal with the problem. Maybe it's the first premise that's wrong. Maybe MJ doesn't hate me, right? If I can have a thought, I go, maybe MJ was short with me and I thought, wow, MJ hates my guts. I start making decisions and having conversations based on that premise. And I'm like, maybe has nothing to do with MJ and I. Maybe MJ has something going on. I shift my thinking just a little bit. I can respond differently, hear differently, and our interactions change. My words change, her words change, and we can actually get somewhere different. So that's the whole idea of this first premise rule is I didn't go after the therapy versus therapy. I was saying, let's challenge premise versus premise. Does that make sense? If we do that, it can open up a little bit of a different type of possibility. So a mild traumatic brain injury, if it's not always a brain injury, just by chance, well, then it leads to a whole different series of questions. Some of them absolutely are, 100%. What if not all of them are? And if they're not, then we need to evaluate and image the brain and the craniocervical junction. Open it up a little bit further to some areas of the body that influence the way the brain works. And if we find that there is damage or disruption of some of those structures or functions in that expanded view, then we have to correct the structural injury to repair the brain, even though the brain might not be directly damaged. It's clearly not working. We can test that. We can prove that. Why isn't it working? That's where we're going today, okay? And so I want to make a big difference in the way we approach things based on policy, especially in the military. I think even in the personal injury world, we need to make changes, but it has to match the right physiology. We get the premises right in different cases, then our treatment protocols will be right, and the sequence of intervention will be right as well, and it will maximize that patient's outcome consistently. Okay? So, this is what I built, is this cascade, right? The blue is before a myotraumatic brain injury. So anything in the blue, anything we talk about, that's going to be in the prevention side of things. I'm not really going to touch it too much today, but I just wanted you to know that's what pre-mTBI is. Can we prevent it from happening at all? The white line, the vertical line, is the point where an mTBI occurs. It's the actual event. The mTBI injury pathophysiology is the instantaneous effect of the impact. Early stage is within the first couple weeks, late stage is within the first couple months, and end stage is years down the road when this person is breaking down. Okay, so it's simple, but it's clear and it's linear. So if you have, this is going off this other premise, let's say the brain is not injured, but there might be another area that is, like the craniocervical junction. It would disrupt the it would cause structural instability in that that individual who had the mild traumatic brain injury. A structural instability in the craniocervical junction will compromise brain health. This is a very simplified version. A compromise in brain health, if left for a few months, will cause a chemical breakdown, a neurological decline, and sympathetic dysautonomia, getting stuck in a fight or flight state. And if those are left long enough, you will see the things we already talked about, right? This is a cascade. So you don't just get whacked and you have PTSD typically. You don't get hit in the head and then all of a sudden you have craniocervical syndrome. These are things that evolve over time and worsen over time. And so if you have a blast injury, the one thing I will say is blast injuries have the capacity to jump time. You have instantaneous breakdowns of the brain. You have instantaneous disruptions of chemical balance, and it is much harder to get these people on track. So if we take this and we expand it out, I can't just say structural instability. I'm not just going to say brain health compromise. It's a lot too simple, or far too simple to really summarize it. So what I put together was a mild traumatic brain injury pathophysiological cascade with a heavy focus on the craniocervical junction, simply because it's an area that's not often talked about, but it has a massive effect over brain health. So that's what this chart is. It is still being evolved. It has room to adapt, but I wanted to go through what happens in the brain from disruptions outside the brain that influence the way it works. So you see up here, we have blast injuries. The reason why it's red is all of this stuff is super accelerated compared to a typical head impact in sports or a car accident. With the head impacts, you're going to see there's an instantaneous disruption of quite a few different systems, and it causes these symptomatic breakdowns and neurophysiological breakdowns. You'll see here, and I want to point this out before we dive into some of these details, in my opinion, from my perspective, from the way I've observed injuries and the way that physiology normally plays out, you should have an inflammatory response to any area that is injured. It is the body's way to normally heal. It shouldn't be prolonged. It should be able to clean out. It should be able to filter through so that you're getting clean material in and waste is leaving. It can be prolonged if the injury is severe enough, but it is by nature a normal response of the body. We don't want that stuff sitting around, especially in the brain. And there's reasons why it does. So that's why that is starred compared to any other thing on the chart. So what I'm going to do is go one by one and start to talk about these cascades and how they are interconnected. So the first, I want to talk about the craniocervical disruption itself. So the craniocervical junction is in the upper neck. It includes the base of the skull, the occiput, the atlas bone, and the axis bone. Okay, the atlas sits right under the skull. It's C1. Running through the atlas bone are some very, very key structures. You have the lower portion of the brainstem that does move past the foramen magnum and into the area where the C1 sits. You have your carotid artery, which sits right in front of the atlas bone. Your jugular vein, which sits in front of the transverse processes, butting up right against it. And then you have your vertebral artery, which runs right through the transverse foramen of the atlas bone before it takes a hard right turn and goes into the brainstem. And so these structures are going to be really critical. We also have some very important ligamentous structures in the atlas bone. One of the more common ones that's being talked about now is the alar ligament. It's also called the check ligament. It actually goes from C2 up to the occiput. So it skips the atlas bone, and it's actually holding the C2 straight to the skull. You have your transverse ligament, your apical ligament. Transverse is right here, which holds the dens against the atlas bone. Apical ligament attaches the tip of the dens to the anterior portion of the foramen magnum. We have quite a few others. I think I have a better image here. Here we go. On MRI, if we take a slice, you can see we have our anterior atlanto-occipital membrane that sits on the front side of the foramen magnum, and it travels down to the atlas bone. We have our anterior atlantoaxial ligament, which goes from C1 to C2. It's a continuation of the anterior atlanto-occipital membrane, so that's going to help resist extensions. We have our apical ligament, which goes from the tip of the dens all the way up to the foramen magnum. Tectoral membrane, which is basically the ligament that is snug up against the dura mater. So that is the last ligament before we get to the central canal running through the foramen magnum. We have, I'm just going over craniocervical. So obviously we have our anterior longitudinal and posterior longitudinal ligaments, interspinous, supraspinous ligaments, ligamentum flavum. These are the ones that are commonly reported on. They're commonly talked about. And if they're injured, that person has probably a very serious whiplash injury. These are the different ones, though. So posterior atlanto-occipital membrane and posterior atlantoaxial membrane, it's a continuation of one to the other, and the dura mater does attach to those as well. So the alar ligaments are interesting. They're very strong, actually. They can resist about 250 newtons of force, about 45 pounds. The transverse ligament, which goes across the atlas bone and holds the dens to the atlas bone, that one can resist about 63 pounds of force. So pretty tough ligaments, okay? The maximum strain, especially on the alar ligaments, is in head rotation. So if we rotate, these ligaments get really, really tight. And they're vulnerable to tear and whiplash with the head turned or a lateral whiplash. Now, there's a reason why we have to talk about the tensile strength of the ligaments up here, because they're much more vulnerable than other ligaments inside the spine. Ligaments are vulnerable to plastic deformation. All right, you ever grab like a Publix shopping bag, one of those plastic grocery bags? If you stick your finger in it and you pull it out, what's left? It's a dent of your finger, right? If you take a rubber band and you push it in and you pull it out, what's left? Nothing. Okay, so plastic deformation is a permanent change in the way that ligament would be able to resist tension. And the other thing that's really important is they have a lot of resistance in slow motion. But if you take a ligament and you rapidly rip at it, it rips much more easily. So when we talk about these craniocervical ligaments, the weakest ones start to tear at about 4.5 Gs of force, which is approximately a 7 to 10 mile an hour fender bender. You can start to disrupt the integrity of the craniocervical junction with an impact that low. 7 to 10. Yeah, around 7 to 10 miles an hour. Men are a little less vulnerable. Women are typically a little more vulnerable because men have more muscle mass and their muscles can resist some of that strain better So a large muscular man, it will take a little bit more force. Women in car accidents tend to have more ligamentous damage. Okay. The tectoral membrane, that sits right here. It's on the interior part of the foramen magnum, and it goes down to the C2. It normally limits flexion. It can sprain or tear in a hyperflexion injury, so that would be like a front end collision. Or if you hit the back of your head and it flexes you forward very quickly. It'll be visualized as a thinning of the membrane if it's sprained, and the thickness will naturally taper laterally, so it's a lot thicker in the middle and it's thinner on the outer parts of the tectoral membrane. A rupture will cause a dural hump or a dural flap, usually visualized on a sagittal MRI. It's very uncommon for the tectoral membrane to have that flap, but on the backside we can, right here. So sometimes we can have this dural infolding. If this ligament starts to disrupt, it can fold inward, especially in extension, and cause the cerebrospinal fluid to have to go over a bump. And it's felt as turbulence inside the head. They'll feel whooshing, they'll feel thumping. It'll be like every beat of their heart, especially in extension. And it tends to be very painful. The dural infolding tends to occur because of a break in it's called the myodural bridge. So the suboccipital muscles attached to the dura mater with this thing called the myodural bridge. It's basically like a ligament. Think of it just like a rope, right? If the muscle contracts, it yanks on the rope and it keeps the dura mater away from the spinal cord. But if you rip the rope between, then that dura mater right here can flop. And when we extend, it has nowhere else to go, so it's going to go inward towards the spinal canal. It can be very painful, and it can be very disruptive and felt internally inside the head. The anterior atlanto-occipital membrane connects the anterior arch of the atlas to the anterior borders of the foramen magnum. It's thickest in the middle, and it tapers laterally, and it can be injured in hyperextension injuries. It's usually the last ligament to tear because it's one of the most resilient ligaments in the craniocervical junction. The apical ligament is by far the weakest, but it connects the superior portion of the dens to the basion. So it's the top of the dens right to the anterior portion of the basion right here. In this image, there is a disruption of the apical ligament. I'm not going over like detailed MRIs. There's a whole nother class we could do on just how to interpret MRIs of the craniocervical junction and why it matters. My point is this. Because of the low tolerance threshold, the craniocervical junction ligaments compared to the threshold of the brain in an mTBI or cervical acceleration deceleration injury, one of the first structures to be disrupted in a mild traumatic brain injury is actually the craniocervical junction. So the difference, typically mTBI brain damage threshold is about 60 Gs of force. And the first ligaments to start to disrupt in the craniocervical junction occurs at about 4.5 Gs of force. So if you have a head impact that also causes any form of a whiplash simultaneously, the more likely of the injury just based on resilience is structural. The skeletal structural in the craniocervical junction rather than the brain. It's not saying the brain can't be injured too, but the more likely of the two, almost 15 times more likely, is that there's some instability in the craniocervical junction. So smaller ligaments will be strained first. I'll fix that. Larger ligaments later, and the pattern of ligament damage tends to be in line with the direction of force of an mTBI. So if we know that they were hit in the back of the head and it caused a hyperflexion injury, we're going to look at certain ligaments to see which ones are damaged. There's ones we would expect to get damage in a hyperflexion rather than a hyperextension. If it's a rotational injury, I'm looking at alars. My first assumption is going to be an alar damage. Okay. This disruptive force leads to a misalignment and aberrant motion patterns of the craniocervical junction. So the bones get shifted out of place and stuck there, and when I'm trying to move my head, it's moving out of place. Here's a good example. Anybody ever dislocate a shoulder? Okay. I have too. It's like horrible. If you try to move a shoulder while it's out of place, and this is a very extreme version of what I'm talking about, but if you try to move it, it will grind. I mean, it will be so dysfunctional and you will damage the shoulder so much worse. So the first step to restoring normalcy in the shoulder and its motion and everything is position. And then once it's in position, then you can retrain motion. It always has to be position first. The same thing is true in the craniocervical junction. However, the extent of the misalignment is not as extreme as something like a shoulder dislocation. So the craniocervical junction misaligns in a complex pattern, right? It shifts around in a weird way, and it's different than any other area of the spine. And it's for a few reasons. So there's no vertebral discs between the occiput and C1 and C1 and C2. So its motion pattern just from that alone is significantly different. Because it doesn't have those discs, it's also more mobile. So have you ever heard how if you have a more mobile joint, it has less stability? If it's less mobile, it tends to have more stability. So mobility and stability, they go hand in hand like a seesaw, right? More of one equals less of the other. And so in the craniocervical junction, it's designed for precision motion of the head. That's why it's built that way. So I can point my sensors, think about this, your eyes, your ears, your nose, towards exactly what I want to. That structure is not built for impact, right? I can get hit in my body all day long. I get hit up here, and it has so little resilience to impacts because it's not made for it. It has a brain inside of it. It's got our hypersensitive sensors that we're trying to point at what we want to look at. So we are dealing with a structure that has no mechanical advantage in impacts. And we're wondering why it's getting damaged. It's because the thing that makes sure you can point it that way, the craniocervical junction, is left vulnerable to increased precision mobility. That's the compromise. The atlas vertebra moves along a convex concave surface. So basically you have your occiput and your atlas bone and it glides along it. And those joints aren't even lined up, they're angled. So it has a very complex three-dimensional pattern. And then from the atlas bone to the axis, the C1 to the C2, it's convex on convex. It actually rolls and glides. And it lifts and moves. So I'm not going to go over all the biomechanics today, but it is not a normal motion pattern. So there's direct ligamentous attachments from the dens of C2 to the foramen magnum and the occipital condyles, and a high degree of rotational mobility between C1 and C2. That's why the dens is called the dens. It's epistrophius, it means axle, right? It's the axis of rotation of the atlas bone in the head. So huge rotation right at that C1, C2 joint. It's designed because we need it to move that way. It just leaves it vulnerable. Ligaments in general are vulnerable to deep plastic deformation. We already talked about this, but the reason why that matters, the reason why it matters that it doesn't return to its original tensile strength is that if it's either newly injured or has plastic deformation, it has less resilience in that structure. This is why someone in a mild traumatic brain injury, something strong enough to potentially even damage the brain, that person is more susceptible to a negative symptomatic effect after a manual manipulation. Like the harder the manipulation for someone who's already compromised in that area, there's higher risk. Okay. And it could be just risk of pain, but if you think of it, if you sprained an ankle and I said, hey, come here, let me twist it for you. You're like, I just sprained this thing. Like, I don't want to twist it again. It makes sense why we wouldn't want to increase aggravation on an area that's vulnerable already from the way it's designed. And then on top of that, those structures, the few that are there that are holding it together are damaged. So we would want to limit intervention to a safe range, especially in the higher grade impacts. And then when there is a misalignment and disruption of the craniocervical junction, it causes a very consistent pattern of symptoms We call this craniocervical syndrome, headaches, neck pain, dizziness, brain fog, pressure in the head. These symptoms can persist over a long period of time, and it'll continue even with the use of pharmaceuticals to reduce symptoms. So basically, like I have people all the time, and they're like, "Doc, I have these migraines. I've been given migraine medicine for 3 years. It doesn't even touch them." Preventative migraine medicine and the ones you keep in your pocket for that moment you know migraine's coming on. They're like, "It doesn't do a dang thing." And it's because the you didn't catch a migraine, and it's not like you can use the pharmaceuticals to swat it away. There's something driving the migraine, and that's what actually needs to be dealt with. So the underlying structural dysfunction must be addressed before a full resolution can be achieved. So that's craniocervical disruption. When those ligaments get disrupted, it causes a craniocervical instability. It tends to lead to craniocervical syndrome that does persist and become more resilient to pharmaceuticals or resistant to pharmaceutical intervention. In other words, you're going to hurt worse and worse no matter what you're taking if you leave it long enough. Okay? So the cerebrospinal fluid. We have our brain, our cerebrospinal fluid, our brainstem, and our atlas bone all highlighted here. The cerebrospinal fluid flow pattern, it's made inside the lateral ventricles and the choroid plexus, so in the center of the brain, drained into the third ventricle, through the fourth ventricle, finally comes out and circulates around the brain and down the spinal cord. We're not going to go into detailed patterns, but what we need to know is it has flow pattern to it, period. The glymphatic system is the drainage out. It's the lymph of the brain, lymph system of the brain, but it definitely has a different design to it. It requires certain cells inside the brain, the astrocytes, to be able to open up the gate channels so that the fluid can be resorbed. It's resorbed in the central sagittal sinus. It drains out the transverse sinus, and that dumps right into the jugular vein, which comes down the neck, right in front of that atlas bone. So that is the flow pattern made inside the brain and flows out. So one of the best things to do when it comes to the cerebrospinal fluid flow patterns and the glymphatic system is think of it like basic plumbing. And the only pump in this plumbing system is the heart. Everything else is driven through gradients. And how open the flow patterns or flow channels are. In plumbing, if you have any flow pattern that's disrupted, valves being closed or anything like that, again, it's upstream, downstream, right? You close a valve in a plumbing system and everything that comes before that is going to be directly affected by the fact that that valve is closed off. So we want continuous flow patterns, continuous production of the cerebrospinal fluid inside the brain, continuous flow throughout the brain, and continuous drainage through the glymphatic system in order for all of the pressure regulation, cleansing patterns, and nourishment from the cerebrospinal fluid to take good effect. And if you disrupt any part of that plumbing, you're going to have problems. So a craniocervical junction misalignment, when the top two bones, the atlas and the axis, get misaligned from the skull, it can alter the flow patterns of cerebrospinal fluid. Think of this. If you had a smooth stream and you threw a bunch of rocks in the bottom of that stream, what would happen to the surface water? Yeah, cause some turbulence on the surface, but the origin of the problem is underneath. So the turbulence of the CSF sometimes can be because the structures that should create a smooth internal surface for the cerebrospinal fluid to flow down, it actually causes turbulent patterns for us to go across bumps and corners. And the bigger the misalignment or the bigger the disruption, the more turbulent it becomes. So what will happen if you're seeing somebody that's had this problem for a long time, a lot of times you'll have lesions grow in the area where the pressure is the greatest or the turbulence is the greatest. It's the same as if I punched you in the arm over and over in the same spot for a few weeks. What's going to happen? You're going to callus, the bone's going to thicken, right? The muscle's going to uh, like resorbent's going to put thicker, tougher material to resist the constant impact. So if you leave turbulence inside the central nervous system, there's turbulent flow patterns, then the nerves themselves will create almost a callus-like effect. Instead of it being able to be soft and malleable and transmit nerve signals very well, it's going to be hard, neurodegenerative, and plaque. It's an adaptive response. So the blockage of the flow pattern or drainage can lead to hydrocephalus sometimes. All that means is we're making more fluid than we're getting out. And it's going somewhere. Hydrocephalus can be all sorts of areas of the brain. But it's got to go somewhere if it can't flow out. And then neurodegenerative conditions are strongly linked to cerebrospinal fluid flow disruptions due to the damaging effect of the aberrant flow pattern. So if you leave the fluid long enough, if it doesn't filter the waste products enough, or the turbulence is just having this impact effect long enough, you will see the development of neurodegeneration.